today's lecture is going to be about crystalline arthritis, so primarily gout and pseudogout. I'm hoping to keep this lecture very both clinically relevant and also relevant to what you guys seem to need to know for your boards. And please, we can kind of keep it informal. I think it's a little hard to watch the chat while I do it, but if you guys want to just unmute to ask questions, that's perfectly fine. And so we'll go ahead and get started. So I know, like, when I was a resident, I used to think gout was kind of boring. But I found, like, as a rheumatologist, and I think in medicine, it's, something that is so simple to treat and see a very notable change and improvement very quickly. And it's really a very satisfying diagnosis. So I think this is something that you guys should definitely be able to at least get treatment started for on the floor or in your primary care clinics. And then, of course, when it gets a little bit more complicated, we're always here to jump in and help. So I wanted to start off with a case, and I know we're on Zoom, but I'm still going to try to have a little bit of audience participation. So I'm going to ask for some of you guys to jump in with your thoughts. So our case is a 79-year-old gentleman. He doesn't have much past medical history, but he's coming in. He's had 3 days of very severe acute onset pain in his knees and ankles. He has a little bit of a fever. His heart rate's up a little bit, a bit hypertensive. And on exam, you note that he has a couple joints that are swollen, they're warm, they're hot, they're very, very tender to palpation. And then he's got some elevated inflammatory markers and slight leukocytosis.
This might be a little low on the differential, but first thing I thought of was septic arthritis. It's a little lower because it's not common for it to be bilateral like this. Mm-hmm. Our presentation is about gout, so I imagine it's on there, but
Perfect.
The podagra is where it normally, commonly presents first, I guess. It's right here.
Sure. Yeah, that's great. I think those would pretty much be my two highest things, right? You can also, other things you can think of with a hot joint would be like a reactive arthritis or other inflammatory disorders. But in this case, when they've got a little bit of a fever and a white count, you certainly should be thinking about the possibility of a septic joint. And I think you said exactly the right thing, is that, of course, he has multiple joints that are inflamed. And so generally, that should put septic joint a little bit lower on your differential. So kind of getting into what the specific characteristics that point us towards crystalline arthritis versus other things. One is a very acute onset, right? These are things that they go to bed at night feeling just fine, and then like that in the middle of the night or first thing in the morning, they're in exquisite pain. And you were right saying that oftentimes the first ever flare is often in the first toe. That's especially true in our middle-aged men who are kind of having a classic presentation. But of course, and I'm sure a lot of you guys have seen, especially at the VA, we have these patients who end up with gout in their hands and all the joints of their hands and their wrists and their elbows. So certainly affects lots and lots of different joints. And the longer you go with this disease, the more likely you are to have these polyarticular or oligoarticular flares. So other characteristics, there's generally a hot swollen joint. It's going to be red. And they're often extremely tender. These are people who, you go and you accidentally bump the edge of their bed and they're jumping up and shouting at you because they're in severe pain. And now I think one of the important points in this case is that this is affecting multiple joints, which should make us think more about a crystalline presentation than something of sepsis. A few additional things that are also consistent with a crystalline arthritis. So the elevated inflammatory markers, right? This is a very, very inflammatory process. And certainly even in gout or sometimes pseudogout, but mostly gout, you can see a low-grade fever. And having a light elevated white count is also not unexpected. So can somebody else tell me what should our next step be to help us define what the diagnosis is in this case?
Arthrocentesis and then a synovial fluid analysis.
Perfect. That's exactly it. So if you have a hot joint, you need to be sending that for studies, especially if you aren't sure. Now, when there's a polyarticular flare like this, you don't necessarily have to tap the joint, especially if there's somebody who has a known history of gout. But if there's any underlying concern that there could be some sort of septic joint involved, you absolutely need to have it tapped and sent. I know you guys don't always get good opportunities to do this, but please, if you are consulting us and we're going to be looking at a swollen joint and you want to join in, please let us know, because we're more than happy to have you with us. We're more than happy to kind of teach you how to do it and try to get you guys some opportunities to do some procedures as well. So getting to what our synovial fluid analysis is, this is kind of a slide that I think you guys kind of need to like imprint into your brains and remember it forever. And I'm sure it will come up on at least one question on your medicine boards. There's two major cutoffs that I think you really need to know. The first one is the difference between inflammatory and non-inflammatory fluid. So non-inflammatory is going to be things like osteoarthritis or maybe like a post-trauma related pain. Generally, that's going to be less than 2,000. Anything over 2,000 is considered inflammatory. So that can be gout, that can be rheumatoid, that can be lupus, that can be infection, any of those sorts of things. And then if you see a white count that's greater than 50,000, you should absolutely be thinking about septic joint. Now in the real world, certainly gout, I've seen it plenty of times causing numbers that are higher than this, 70,000, 80,000. But that's not to say that you can't have both an infection and gout. And so certainly you would want to make sure that it's been sent for culture. And I think if the numbers are higher than that, empiric antibiotics are generally not a bad idea. All right, so taking a look at some of different types of crystals we can see in the joint. So what if we start with this first one over here? What shape are those?
I think the first one is a spindle shape. So I would say this is like classic gout. So like sodium urate crystals.
Perfect, yeah, so that's great. This second one, these ones are a little bit more kind of squarish, right? So these ones I would consider to be like rhomboid shaped. And then this one over here is a little bit of just an extra credit piece. These ones I kind of like call them, I think they look like Tetris pieces, but these are actually cholesterol crystals that can also be seen in joints. So here we've got your first up, the monosodium urate crystals. And these again are always going to be needle shaped and negatively birefringent. This next one are calcium pyrophosphate crystals. So those are our Pseudogout crystals. These are rhomboid shaped and positively birefringent. And whether they're negative or positive, it sort of has to do with what color they are when they're aligned with the polarizer on the microscope. I think for you guys, it's probably just more important to remember if they're negatively or positively birefringent. In terms of, for boards and things, but I think this is the second slide of the two most important. This is probably the second most important slide to kind of know what's going on for your boards. This third picture is some cholesterol crystals. These can be seen deposited in rheumatoid arthritis and also OA, but can also be somewhat inflammatory in nature. All right, so talking about treatment of an acute gout flare. Sorry about that. So what are our options here? These are kind of going to be standard options kind of throughout, so you'll hear them repeated again later. But your major categories are NSAIDs, colchicine, steroids, and then ice. Don't forget the importance of ice. It can be very helpful in these really inflammatory disorders. And so certainly making sure that a patient gets an ice pack and they're putting it on 3 or 4 times a day can actually be very helpful. But we'll talk a little bit more about the rest of these other categories. So NSAIDs. I did want to note that, I think in going through medical school and some of the reading, often we specifically get stuck with indomethacin. But really there's no specific reason that you would have to use that one. I think honestly there's other ones that are probably better and have a bit better tolerated. The 2016 ACP guidelines have absolutely no preference for any specific NSAID. And then they also, interestingly, I thought, did not find any particular difference in symptom resolution for a simple gout flare with use of NSAIDs versus use of steroids. So that being said, I would say that probably the biggest factor in whether you're choosing to treat with NSAIDs versus steroids should be the renal dysfunction, right? Because certainly we would want to avoid those in our renal patients. And then with the NSAIDs, generally you want to do 5 to 7 days of treatment to ensure that they really have gotten through the entire flare and that they're having good resolution of their symptoms. Up next is colchicine. The important thing to know about colchicine is it's really best early on during the flare, like between the first 24 and 36 hours. If you've gone longer than that, if they're coming in 2 or 3 days or even more after they've started having these pains, it's probably not going to be incredibly effective. And I just wanted to kind of review some of the dosing for you guys so you kind of know what you need to do if you see a patient coming in like this in the middle of the night. Or you get called in the middle of the night to treat someone who thinks they're having a gout flare coming on. The acute dosing is 2 tablets because generally they come in 0.6 milligram tabs. So 2 tablets immediately, followed by an additional tablet an hour later. And then they would hold off on further colchicine until like the next day. You also can consider after that initial acute dosing doing either once or even twice daily until their symptoms resolve. I would really, part of the reason you would choose between once versus twice daily would be things like any renal dysfunction you would want to be more cautious in. And then if there's somebody who has any side effects from the colchicine. So most commonly is some GI upset, particularly diarrhea or abdominal pain. And so I always like to tell people that before they start it so that they kind of know. And that way they have expectations and it doesn't surprise them. And plenty of people have no GI issues with it, but I just think it's a good thing to warn them about that. And then again, if you're talking about somebody who has some severe renal disease, particularly creatinine clearance less than 30, you do need to reduce the dose. So you can still do the acute dosing, but then you need to hold off on any additional colchicine because they're not going to clear it. You can also do a more extended dosing where they take just half a tablet when they first initially get that flare. So a lot of people will say like, oh, I feel a little tingle coming on in my toe or my heel or, wherever they typically get it. And they kind of know that things are starting to act up. And that's really when you want to get them to get started on that colchicine. And then again, in renal dosing, we do it far less often. So you would not repeat it until several days later. For people who are on dialysis, colchicine is really best avoided. It's not a medication that can be dialyzed off, and it certainly has lots of interactions with other medications. So definitely, if it's somebody who's on dialysis, I would be very careful and would probably prefer to avoid it if at all possible. And then finally, and this is, I'm sure, what you guys see us do a lot on the floor, is use of corticosteroids. So typically we will reserve these for people who are having severe flares. The gentleman who comes in with a whole boxing glove, swollen hand from their gout flare, or who has both knees, both ankles hurting, or if they have renal dysfunction and therefore you're preferring to avoid your NSAIDs and avoid the colchicine. So generally, in terms of starting treatment, starting a taper for this, you can usually go with somewhere between 0.5 and 1 milligram per kg. And they can do it for 5 to 7 days. And some people who have more chronic or severe cases, the people who come in and they have a flare and then they come back to the ER a week later and then back to the ER again 3 weeks later, that kind of have this never fully resolving flare, you would want to do a much longer and slower taper down of the doses so that you can ensure that you're fully treating them and really helping them to fully resolve the flare, because otherwise they will certainly bounce right back to you. Now your options for steroids, certainly PO is easy, especially if they're not in-house, but IM is also an option. We definitely do IM a lot more here at the VA than we do at Georgetown. In that, there's a couple things to keep in mind. One, it does take a bit longer to work. So really, if you're doing IM, the onset is somewhere about 24 hours later that you really start seeing its effects. So it does take a bit longer, but because of that, it also has a little bit of like a depot effect where it actually persists a bit longer with its action as well. So sometimes, that's helpful for somebody who has like a moderate gout flare. We want to kind of cover them through a couple days. The IM can be a good option. And then finally, we also can always do intra-articular injections, but those are really best if there's either one joint that's really, really bad compared to the rest, or if they just have one joint that's involved and it's just having a hard time resolving. But of course, when we're having like a severe polyarticular flare, intra-articular is not always helpful. Anybody have questions so far? Perfect. And then finally, if you have somebody who has an unresolving flare, who has, questionable renal status, and who just isn't getting better after your treatment, Anakina is also an option. So it's an interleukin-1 antagonist. I believe it's off-label use if you're using it for acute flares, but still it can be very helpful. The dosing is sub-Q, so it's a little bit harder for someone, to be having that at home as their kind of treatment for acute dosing, but it is an option. And usually what they do is when it starts to flare, they take it and then do it once daily for somewhere between 3 to 5 days. And generally, it does lead to pretty quick resolution. But again, it's very expensive. There's some, other issues with doing it. It's subcutaneous, so somebody has to learn how to inject themselves. So there are some difficulties with using it. It certainly should not be your first line. And I think if you're getting to this point, then definitely you should have a rheumatologist involved, just due to familiarity with the medicine, if nothing else. All right, so back to our case. So, we did his joint tap. We found out that he had the monosodium urate crystals present. We thought it was gout. We went ahead and we did our acute dosing treatment for him. And we're getting ready to send him home. And the question is, what should we do for him before he leaves? We find out his uric acid is 12.9, and he's apparently a frequent flyer, right? He's been coming in several times this year for gout flares. What should be our next first step?
You consider prophylaxis of some sort, like allopurinol or prophylactic.
Yeah, that's perfect. So that is correct. So, he's somebody who clearly, and we'll go over this in more detail later, but he clearly meets indications to be on what we call urate lowering therapy. So that's therapy that's going to reduce his uric acid levels. Now, you're right. He also is going to need to be on prophylaxis, and let's talk about why. But I think the other question that everybody always asks is, when do we start the allopurinol? And I think there's a couple of schools of thought on it, but there is some specific data about what we should do. Certainly when you're starting urate lowering therapy, there's always a risk that you're going to induce somebody to flare. Why? Because you're having some urate precipitate into the bloodstream from the tophi that are, kind of sitting quietly there. And as you start urate lowering therapy, when you lower the urate in the bloodstream, those crystals that are, outside of solution are going to start precipitating into the bloodstream, and therefore be at risk for starting a flare. But certainly in this person, we saw that his uric acid was quite high, right, at 12.9, and we know that he's had lots and lots of flares. So he clearly needs to be on urate lowering therapy. And it sounds like if he's having a lot of trouble, we probably want to get him started on something where we can still monitor him. So this study in 2012 was from a VA, I believe, up in upstate New York. And they did this study where they showed that, starting allopurinol while the patient was still hospitalized did not have any increased risk of side effects, and did not have increased risk of flare, as long as you have the patient on some sort of prophylactic medication. So what things are prophylactic? Generally, we would lean towards saying colchicine. You can also have them on, if they're still on an active steroid taper, that certainly is going to help cover them. NSAIDs can also be prophylactic, but I would say that for the most part, we reach for colchicine as our prophylaxis. So again, just to clarify, urate lowering therapy is going to be your allopurinol, your febuxostat, things in that category, whereas colchicine and steroids do not actually affect the uric acid at all. They just help to treat and prevent the actual flare. So the actual inflammatory nature of the neutrophils attacking those crystals. All right, so let's talk a little bit about urate lowering therapy. And I did want to point out that there are some differences between what the ACR recommends, and that's our American College of Rheumatology, and what the ACP recommends. So for your boards, I would probably lean more towards the ACP guidelines for this. So both of them recommend initiating urate lowering therapy for anybody who has frequent flares, and that is defined as having more than 2 flares per year. In terms of when you're going towards the ACP guidelines, if somebody has tophi, CKD, or a history of kidney stones, they primarily recommend shared decision-making with the patient, not necessarily jumping straight to urate lowering therapy. Whereas on the rheumatology side of things, if somebody has presence of tophi or presence of bony erosions from their gout, which we'll talk about a little bit later, those are certain recommendations to absolutely be on urate lowering therapy from our standpoint. The most recent ACR guidelines also recommend starting urate lowering therapy even sooner if the patient also has ongoing kidney disease, elevated uric acid greater than 9, or any history of urolithiasis. The other important difference between these two sets of guidelines is kind of the recommendations of when to stop it and how to treat. So ACR pretty specifically has a recommendation of targeting a uric acid goal of less than 6. And that specifically is due to the solubility of uric acid in blood, which hits somewhere between 6 and 7. So if you can get uric acid less than 6, then you're going to help dissolve a lot of those tophi and really prevent flares. For our patients who do have tophi and or bony erosions, we actually recommend an even lower goal of less than 5. And then we overall recommend continuing it indefinitely. Whereas on the ACP side of things, they primarily recommend kind of treating to minimal symptoms, which I think is somewhat hard if you have somebody who is non-compliant or somebody who doesn't see you all the time. But they recommend treating to kind of minimize symptoms, minimize flaring, and then they consider discontinuing medications if the person is asymptomatic, has a uric acid less than 7, and then as long as they've been treated for about 5 years and aren't flaring. So I wanted to take just a few minutes, because I think pictures are more fun to look at, talking about some of the manifestations of gout outside of the acute flare. So tophi are essentially deposits of uric acid crystals that can occur most commonly on the outer parts of the body where the temperatures are cooler, but certainly they can be very disfiguring, and they can end up being painful themselves if they're involving things like tendons or ligaments. So here we see a lot of tophi on the hands. This is somebody with rather unfortunate disease on the foot. And then very commonly, the outer helix of the ears is a good place to look at it. So especially if you're seeing somebody in the hospital and you just want to do a quick scan, make sure you're taking a look at their ears to see if they have any deposits, because that can tell you, about how aggressive you're going to need to be to treat this gout. And then this, I just wanted to include here, this is a patient who had this soft tissue sort of prominence here on the olecranon of his right elbow. And this all here, this is just tophi as well. And that's another good place to look for them. Often, if you kind of feel within the olecranon bursa, you can kind of feel either a sandiness or a little like gritty crystals in there, and that's tophi that you're palpating. So I always try to make sure to do that on our gout patients. Now, the other thing to look for is bony erosions. You don't necessarily need to x-ray every gout patient that you see, but certainly it can be a very destructive disease. So it often has these what we call rat bite lesions where there's overhang and it's a very abnormal edge. So you can see here there's a big erosion in this toe. The first MTP is full of cyst and then these big erosions here. This is the midfoot, somebody who has clear erosions all along there. And then this is a gentleman who had pretty severe tophaceous disease. And the red arrows are pointing at areas of bony erosions. And then these yellow areas are areas where you can see kind of the dense material of tophi deposited all throughout his hands. And then this is just a good point. Another way of imaging or looking at gout is through what's called a dual energy CT. And that you can actually specifically pick out different densities and the CT itself will indicate where there's deposits of them. So on this one, you can actually see usually the green is where you have monosodium urate crystals. And often I think the purple is usually calcium deposits. So if you're not really sure, do they have a big tophi? Do they have something else? Sometimes dual energy CT can be helpful in determining kind of what's going on. All right, so now that we kind of know who needs to be, what the recommendations are for who to start urate lowering therapy in, let's talk about what options we have available. So the first and most common and what I would say really should be your first line therapy is allopurinol. This is a xanthine oxidase inhibitor. The most common side effect is rash, but there are certainly some groups in which there can be more severe side effects, and I'll show you those in just a moment. Now, with dosing it, the goal is really always need to start low and then up titrate slowly. And that's even more important in your patients who have any renal disease because they're not going to clear it very quickly. So usually we start at 100, and then in anybody with like CKD 3 or worse, you would start with 50. And then usually what we do is over about every 2 to 3 weeks, you can consider up titrating slightly if you haven't yet reached your goal uric acid. It's important to know you can actually go up to as high as 800 milligrams as recommended by the FDA. And I believe in some other countries, they actually sometimes go even higher. The one thing you really want to watch out for is allopurinol hypersensitivity syndrome. So this can appear as a very diffuse, painful red rash. These patients can also get things like DRESS or Stevens-Johnson syndrome. And it's somewhat more common in patients who have this HLA B5801 haplotype. Generally, this is most commonly seen in people who are of Han Chinese descent as well as Thai people. And then our recommendations, there's also some higher prevalence of this allele in African American patients. So there are recommendations from both the ACR and ACP to check this allele before starting allopurinol. And also in those who have stage 3 CKD or higher to know if you're at increased risk for hypersensitivity. Up next on our list of urate lowering therapy is febuxostat or Uloric. This is also a xanthine oxidase inhibitor, but it's a slightly different shaped molecule, and so it doesn't behave exactly the same way. There is some cross-reactivity between allopurinol hypersensitivity and risk of a similar reaction with Uloric, but it is generally decreased comparatively. Usually we, again, dose at either 40 milligrams or 80 milligrams a day. In Europe, there is approval to go a bit higher, but generally we use one of these 2 doses. Side effects most commonly are abdominal pain, diarrhea, myalgias, and then just to be of note, there is a black box warning about increased risk of cardiovascular events and cardiovascular death. that came from the CARES trial about, 5-6 years ago now. But in subsequent studies, that really hasn't been shown to necessarily always be the case. So something to be aware about and counsel your patients on, but doesn't necessarily have to be an absolute stop to your prescribing. And then finally, if you have somebody who really isn't responding, or somebody who has really particularly severe tophaceous burden, Pegloticase is also an option. This is a recombinant enzyme, as most humans don't make uricase, but a lot of animals do. So it's a recombinant version. It's linked to polyethylene glycol. And it requires an infusion every other week, but it can very rapidly reduce uric acid to essentially undetectable levels. And so that's especially important in somebody who has severe tophi, who's having decreased ability to complete their daily tasks given tophaceous burden. Those are the kind of people you want to consider this in. There are quite a few risks to consider. They certainly can have a hypersensitivity reaction during the infusion, and they also can develop antibodies to the drug itself. So specifically with these patients, you have to very closely monitor the uric acid before every infusion, because rising uric acid can be indicative that they're developing antibodies to the drug and rendering it inactive. And then finally, it's also contraindicated in patients who have G6P deficiency. So another thing to check before you get them started on it. This again is kind of definitely not your first line. It's probably more like your second or third line. And if you're at the point where you need something like this, you're probably wanting to get your rheumatologist involved. Now, talking about options for prophylactic therapy. So like I mentioned, if we're starting allopurinol, we're going to lower the uric acid, but there is certainly a risk of flare while we're doing that. And so particularly you want to make sure you're using prophylactic acid or prophylactic therapy while you're up titrating your medications, or if you're starting it during a flare. So usually what we use is just a once daily single tab of colchicine every day. If they have renal dysfunction, you do need to be very careful. You definitely need to dose reduce. And sometimes you even should try to avoid it, particularly if they're like on dialysis. Usually we only do like half a tablet once a week or something like that. So very limited. And again, while you're up titrating their allopurinol, trying to get the uric acid low, you definitely want them on prophylactic therapy. Once you've gotten them to a steady dose of the allopurinol and they've gone several months without a flare, then you can consider taking off the daily therapy and just leave them with acute dosing of colchicine. Colchicine does have lots of interactions with different medications, so that's something to always be aware of. And particularly, colchicine can also have a myopathic side effect, causing a cystic or vacuolar myopathy, and that is actually increased if the patient is also on atorvastatin. So generally, it's okay to be monitoring, but this is less likely if you're on Prava or rosuvastatin. So that's a consideration to also change their statin while you have them on colchicine therapy. And then I just wanted to review, some kind of critical triggers and risk factors. The ACP guidelines actually don't necessarily recommend any specific dietary counseling or specific avoidance. But I do think it's still important to talk about, especially key triggers with patients, because those things they probably should avoid those. So particularly alcohol, mostly beer and hard liquor are big triggers for people. Shellfish and red meat also can be. And then high fructose corn syrup, which is in essentially everything, is also a big trigger. So I always like to ask my patients, do you drink lots of bottled juices or teas or other drinks that might have that in it? There's also lots of medications that can trigger gout flares or increase uric acid. So particularly thiazide diuretics, HCTZ, chlorthalidone, all that group. And so if you're choosing something for blood pressure, I probably would avoid those. And if you have somebody who already has bad gout, Loop diuretics also certainly can be a trigger. I'm sure you all have seen by now a course of somebody who got a pretty bad gout in the case of being diuresed for CHF. And then other things are calcineurin inhibitors and lead toxicity. And then certainly there are other just physiologic things that we can't necessarily avoid. So obesity, chronic renal disease, and then acute inflammatory episodes. So things like infection, surgery, MI can also be triggers. So if you have somebody who you know has bad gout and you're seeing them for something else, just kind of keep that in mind, that if they're here for an infection that's not related, but they start having a lot of pain in the toe or the knee, that maybe you should consider, are they having a gout flare? All right, so that is kind of, go ahead. No, okay. So that's kind of all the big things about gout. I'll move on to a little bit about calcium pyrophosphate disease, and then we can talk about if anybody has questions, and we can do a couple of mix-up questions if we still have time. So calcium pyrophosphate disease comes in essentially 4 different types of major presentations. I think the one clearly clinically that you guys need to be the most aware of is what we call pseudogout, right? So acute crystalline arthritis from the calcium pyrophosphate. And then also just asymptomatic deposition. So certainly you might see this on x-rays, right? Chondrocalcinosis. And I'll show you a few images of that as well. And then the other thing, this more chronic inflammatory arthritis is also known as pseudo-RA. It often happens in older women. It often affects the MCPs, can be symmetric. And so just something to kind of be aware that it exists. It's quite rare. So I just wanted to go through and show you guys a few pictures of chondrocal. Certainly, I think these are things you can try to seek out on your own when you're treating patients. So this very thin line of cartilage that has you know, sort of increased density here is chondrocalcinosis in the shoulder. And then we often, another area we often see that is here in the what we call the TFCC. So this is the triangular fibrocartilage area. And you can see here we have some chondrocalcinosis of the wrist. In this case, we also see another very common finding of CPPD, which is that this scaphoid and this lunate have this big space in between them. And that's very common to CPPD. And sometimes even this capitate bone can actually come and slide down more between them. And that is called slack wrist and actually can require surgical intervention for kind of repair and stabilization. And then just a couple more images. These are knees. That's probably the most common place you guys will see chondrocalcinosis. So here, just kind of within the joint space itself, kind of just laying in there along the hyaline cartilage. And then this one I kind of threw in because I think it's one of Dr. Welton's favorite things. This is a CT. This is the C-spine. This is the dens of C2 in the atlas. And kind of all here you see this increased density, and that's all calcium pyrophosphate deposition. And this is called crown dens syndrome. And it can, it can present with very severe neck pain, severe headaches, and again, it can still be inflammatory, so there could be some fevers or elevated white count, elevated inflammatory markers going on with that. Another thing to be careful of, so CPPD is meant to be a disease of the elderly. It should be seen people greater than 50, and it certainly, the prevalence increases with frequency every year after age 50. But if you see it in somebody who's younger than that, you need to be considering other conditions that it might be associated with. So particularly a lot of metabolic issues. So hyperparathyroidism, hemochromatosis is a big one, hypophosphatemia and hypomagnesemia. And so essentially this means you need to do a pretty more aggressive metabolic workup. And here on the side, I just wanted to show you guys, this is a patient with CPPD, but they have this kind of hallmark finding of what we call hook osteophytes. So if you see here, they kind of have this little like hook coming off the tops of these distal metacarpals, and that is not normal. And that is very common in CPPD that's associated with hemochromatosis. And then you can see in their, like, all their carpal bones are far too close together and have a bunch of cysts in them and look kind of a mess too. So how do we treat this? Well, generally it's most important in the acute setting. So kind of our same three big guys, NSAIDs, colchicine, and prednisone. You know, I think CPPD often has a much slower and more indolent presentation than gout. And it often lasts a lot longer too. So it often needs I think a longer taper to really make sure you're resolving the flare. I feel that often also CPPD can be more often monoarticular. And so in that case, intra-articular steroids can be a little bit more helpful, I think. And then, you know, there's not great data for prophylactic treatment. Certainly in some folks, we do like a daily colchicine for a long time, or even a little itty bitty tiny dose of prednisone. But there really isn't fantastic data to say one should be better than the other, or even that they necessarily are really particularly great at preventing these flares. So we've got a few minutes left. I think I'd like to do maybe just one of our mix-up questions, just to kind of help us synthesize everything that we've learned. Why don't I go ahead and read the question, and then we'll talk about the answer. So a 78-year-old female is evaluated for a 2-year history of gout with progressively more frequent and severe attacks. So this sounds somewhat like our case earlier, right? She currently has pain and swelling in the right second finger. And we know that her medications are lisinopril, Lasix, metformin, and she's already on a high dose of febuxostat. She's allergic to allopurinol. And then she looks like she has an elevated ESR, a creatinine that's a bit high, and then she has an elevated serum urate. And we want to know what is going to be our most appropriate next step. It looks like she's still having frequent flares. She has an elevated uric acid, so she has a reason to need other urate lowering therapy. And she's also currently above the goal. So probenecid is an option, but it's not great in people who don't have very good renal function already. So that's not really going to work. Switching from an ACE to an ARB, there is some evidence that losartan does have some uricose-uric effects, so helps to limit some. But again, that is somewhat limited by renal function. And then we don't really want to continue current treatment because clearly what she's on isn't working for her. So she would be a good patient for Pegloticase, given allergy to allopurinol and continued frequent attacks on current therapy.